And we are live, Senators.
Good morning. This is Senate Health and Welfare, and it's February 9th. This morning, we're going to continue with testimony on S37. And we're going to start out with folks from our public institutions of higher education, and then move on to other people who will be testifying, including the Department of Health and the Vermont Right to Life. So, good morning.
Good morning.
And Wendy, have you been in committee yet? Do you know everyone around the table?
I do not, actually.
So we're going to do our introduction, and hopefully Catherine Levasseur and Mary Han Beerworth, who are also with us this morning, and Patricia Turley, who's here, will then this will serve as introduction for everyone. So let's start with you.
Good morning, Wendy. Martine Keeler from Burlington.
Good to see you.
Good morning, Dave Weeks, Rutland County, live in Prague.
Nice to meet you.
Nice to meet you.
Kenny Lyons, Chittenden Southeast.
Good to see
Terry Williams, also from Rutland, where I live in Pullman.
you. Nice to meet you. Hi, Ruth. Nice to see you.
Nice to see you too.
I'm Wendy Koenig. I'm the Executive Director for Government Relations at the University of Vermont. I used to run the private college association before I went to work at the university, but I've been at the university for about 15 years. And I'm pleased to come in and testify on what we think about this bill this morning. I'm going to start out with a little bit of a personal anecdote. The timing of this bill is very interesting because I have a sister who lives in Lincoln, Nebraska, and she is a professor at the University of Nebraska and has 2 children. And she was in the Nebraska legislature yesterday, which is the only unicameral legislature in the country, which I think is interesting, to testify on a bill that is exactly the opposite of this bill. There is a bill that she was testifying on that would eliminate healthcare, gender-affirming healthcare for transgender youth. And that is of personal interest to our family. So this, I will say, I am proud to testify on this bill on a personal level outside of my role at UVM, because I think it's important for all people to be able to receive healthcare. So in terms of what you have in the bill, I'm going to tell you a little bit about what we currently offer at UVM, and then I have a few questions of areas of clarification that I'd like to ask if that's okay.
Sure.
So currently at the University of Vermont, we offer LGBTQIA and gender affirming healthcare through our student health facility. So on campus, we have student health that is relatively traditional, that offers people doctor, nurse practitioner, and nursing services for things like I have a sore throat, or I need a COVID test, or from anything relating to those sorts of things to what we call CAPS, which is our counseling and psychiatric services, where you can receive psychiatric care or psychological counseling as a student. There's drop-in services, and then there's also regularly scheduled, more robust services in that arena. Our on-campus, and I believe I sent the chair some examples of what we do on our website, and I'm happy to share that with the whole committee, but we provide services for gender-affirming care through student health services, meaning folks can receive hormone therapy if that's something they're already doing. They can receive that through the University Student Health. They can go to the counseling and psychiatry services for counseling. We have a unit that's called Positive Sexuality Support that's also framed in the counseling world, and the PRISM Center, which is for LGBTQIA students to interact with similar students. In terms of reproductive health, through student health, we offer the general array of reproductive services like birth control, those kinds of things, and all of the counseling that occurs there is to refer students out to services in the community. And that is, Ruth and I had discussed that is medical centered counseling. If someone wishes to receive another kind of counseling, we can refer them out to any kind of different service that they would want. But the referrals and the services that we provide in terms of reproductive health counseling on campus are strictly medical. In terms of services that we don't provide on campus, we do not provide any kind of surgical services on our campus through student health. We are very fortunate as the University of Vermont to be affiliated with the University of Vermont Medical Center, which is for most of Central Campus a 1-block walk. So if people need some kind of surgical service, they can be referred to UVM Medical Center or other services in Chittenden County. So we have a wide array of transportation services, bus service that's free for students to access anything they would need. So I think that in terms of the language of the bill, we are mostly in compliance. The questions that I have, I know that in the language it's saying offering services or referrals out to other services. And I'm assuming that or is going to stand and be fine if we're not offering surgical services on campus. The other question I have is, I spoke to our general counsel before coming in this morning, and we feel that creating a plan in conjunction with the Department of Health would be something that we're well equipped and able to do. We're just not really sure what that plan would look like and what the vision is for creating a plan. It says create a plan, but we don't really know what that means. So we thought we would ask if anyone has ideas on what the plan should include.
It sounds like you have given us the framework of a plan that you already have in place.
Yeah.
So, and whether or not additional work needs to be done is a question that we will also ask of the Department of Health.
Okay.
So, yeah, go ahead, Senator Harden.
Yeah, and thanks, Wendy, and you and I chatted quite a bit about this before session, and the whole sort of idea of a plan was largely based on the Massachusetts law for institutions in Massachusetts that didn't really do what you all are doing at UVM. So there was the need for them to sort of step up and say, okay, we need to provide or have a plan for these services. So I think if UVM is already doing most of them, maybe it's more of a report about this is what we're doing and how we're sort of covering the things that are necessary. And you know, you've just done it verbally, and maybe it's just more formally so that we state knows that you're in compliance, kind of thing. That's sort of my thought about it. But,
Yeah, no, I think it's a good idea. And so if you have your information in writing, we can put your testimony on our webpage. That would be terrific.
Sure.
And then I do agree with Senator Hardy, and I don't know what other folks are thinking, but we have enough information here that we don't need to go through this whole, have you go through this whole process. But it would be helpful, you know, in future, just to come back and talk about what further work might happen as a result of the conversation that's going on with this bill.
Yeah.
So it won't be a report. It'll be maybe a presentation, may be available for, or the legislature may request a presentation. How's that?
That sounds
We'll ask our leg counsel for something like that. I think the Department of Health might be happy about that as well.
Yes.
yeah, I wonder, I mean, we would just have to modify the language, obviously, because
Yeah.
they're called readiness plans, and it sounds like you're ready already.
Yeah. And I want to make two other points, if I may. And one is that I think it's important to note that our goal at UVM is to provide the best healthcare we can provide for all our students, no matter what their needs are. So we want to have equal opportunity access to every kind of healthcare that people need. Students are required to be covered by either student health insurance or their family's health insurance. And so their insurances pay for many of these services. I also want to note that we are very lucky based on where we sit geographically. So this is easier for us than it is for our colleagues because we are literally right next door to an academic medical center. So that it makes a big difference. It makes this a lot easier for us than it does for many of the Vermont State colleges, but also some of the private colleges in the state that don't have walkable, easy access to all kinds of healthcare services that we have at UVM. So I think that's important to recognize.
Okay, thank you.
Mhm.
That's very helpful. I think we're probably good.
Great.
Yeah.
Nice to meet you. Thanks for having me in.
We may see you another time, we don't know.
Well, I'm around a lot, so.
We have Patricia Turley and Catherine Lavasser, both of the Vermont State College Assistant, and welcome.
Thank you.
It's a pleasure to have you here. But are you testifying on behalf of
I am.
everyone? Okay.
Yes, I am. Catherine is present. However, unless there's a question I can't answer that she can,
Okay.
I'll be providing you with our testimony.
So why don't you introduce yourself for the record, and then we'll listen to your testimony. And if you have it in writing, I didn't see it on the webpage.
I hadn't submitted anything to you yet,
Okay.
but I do have it in writing and can do
Good.
that.
All right, excellent.
Yeah, I'll write that down. Well, good morning. Thank you for this opportunity to speak with you about S37. My name is Patty Turley, and I am the General Counsel for the Vermont State Colleges, as you indicated. We have 3 institutions with residential students at 4 primary locations in the state: Castleton, Linden, Johnson, and Randolph, with some students also residing in Williston and Killington, small populations there. These rural campuses serve roughly between 4,000 and 5,000 students combined. Vermont State Colleges also includes the community colleges of Vermont, with a presence in at least 12 locations and serving thousands more students, none of whom reside on any CCD property. The 4 main campuses offer a range of medical and mental health services. These are not consistent from campus to campus, and they are provided by nurses, physician's assistants, and licensed mental health counselors. Due to the varying student needs, our campuses provide a varying level of medical services, and mental health counseling is a focus of our student care. While we welcome and support all students, regardless of gender identity, we do not provide gender-affirming medical care or most other medical care within the campus setting. CCD serves commuting students who reside in Vermont communities. Our CCD students receive medical care from their selected providers. So we don't provide healthcare services within the college setting, but if the students ask for our assistance, CCD works with the Working Bridges to 11 coordinator, which is a United Way function, to refer them to an appropriate healthcare provider in their community, depending on what the student is seeking. So because the medical services described by S37 are not provided on site, not the gender affirming care and not medication, abortion, or other related services, we refer students out if they come to us to ask for this information. We might refer a student with abortion questions to the nearest Planned Parenthood, as an example. Or we would provide students with gender affirming care needs with the names of local provider options in their communities nearby. To our knowledge, we've not had complaints from students about our ability to provide them with these referrals for the options. And one concern that we have, although we certainly support making sure our students have this access, is we don't have expertise in this area. So unlike the University of Vermont, who could reach to their partners across the way, we don't have that level of expertise. We would need to rely on outside experts to develop something that is more than the kinds of referrals we make. We are very responsive to our students. That is our primary goal, regardless of what it is that they're seeking. It is our goal, and we certainly hope that we're being responsive to our students to connect them with professionals, the right professionals for what they are seeking. So some of our concerns would be the resources that we might be expected to, we might have to consult with outside experts to prepare any more formal readiness plans than we have. But the folks that we do have on campus, they certainly research these issues themselves, but don't have a level of expertise that would be perhaps appropriate for the plan, depending on how detailed the plan might want to be. We would seek assistance if the Department of Health was able to provide us with that level of this is a basic resource that you should be providing under this. We would certainly welcome that. We would want to be able to make sure we can meet our students' needs, and we would want a readiness plan to reflect that our student needs are quite varied. Other than that, I do just want to express our support for making sure our students do have access and that we are ready to connect them with the resources since we're unable to provide them on site.
Do you have information about the students who have requested for support services for gender affirming care, or for who have come on campus who need a continuation of medication for gender affirming care? Do you have any data? And then also for other reproductive services, including abortion?
I do not have any specific data. We do have a population of students that are undergoing gender affirming care, and if we're able to support them through the limited medical resources that we have, we do that in the same way we would support any other student with a medication need.
Okay, do you have sort of educational outreach both for these kids and for others, students, young adults, and others? So, workshops, meetings, educational, anything.
So I don't have specific knowledge about workshops or other very formal outreach, but I do know that there is outreach on the campus with students because we do have very active populations of students who are either seeking care or supporting others who need care. So they're very aware of these issues, our students, and I know that there are activities on campus that support that, but I'm not aware of formal outreach.
Yeah, so I'm thinking about all the campuses that you have in Castleton, of course, probably has been the longest in place and most robust. They haven't changed recently. And then I think about Linden, St. J, St. Johnsbury, and Johnson. Williston's probably more limited and more greater proximity to UVM.
Yes.
Center. But so is there some kind of a universal plan that you have that would bring those campuses together? Have you thought about doing that?
A universal plan of outreach
Of outreach and support. I mean, as you said in your testimony, there's a significant amount of expertise that's required to support kids who are either undergoing or seeking gender affirming care.
Yes. I'm not aware of a specific outreach that we're planning on. However, we have a new chief diversity officer that's new for us with a university structure combining the resources. We now have a chief diversity officer, and they are working hard on many kinds of outreach. I can inquire whether there is any outreach that would be related to medical
Okay.
support.
And then given the language that's in the bill, and you heard the testimony from Wendy Koenig, and certainly UVM is in a very different geographical location, we get that. But they've also had a very strong university medical center for kids, for students. I think they're kids.
I understand.
So your comments, do you have any specific comments about the language that's there? You said you'd welcome a plan if the Department of Health presented it to you. Are you willing, is the NVU willing to work with the Department of Health and some kind of coalescing all everything that's going on and maybe expanding, improving, whatever?
Well, so by the time that the plan as envisioned by the bill would be ready, we would be Vermont State University and Community College of Vermont.
Right.
So we would be the
Yes.
two institution, right? So we certainly want to support this, and
Okay.
and as long as we can find the right resources to as long as those are available to us to create a plan. So I think that the detail is really in what is the Department of Health plan going to be looking for, and that's not
Okay,
clear to me from the bill.
Okay.
But certainly it sounds like the approach should be to ensure that our students have access to the information that they need.
okay. Thank you. Senator Hardy.
Madam Chair. Thanks for being here. And I totally understand that you're in a different situation. And I actually tried to reach out to Catherine, who I see is on the screen, before the bill was introduced to talk to her about it. And we never were able to connect. But I'm just looking at the website just of Castleton, for example, on their Castleton Wellness Center. And it talks about mental health services and sort of if you're sick, like have the flu or get COVID, presumably. It doesn't even seem to mention reproductive health care or anything beyond, or transgender care or anything beyond those two basic things. So I think that a lot of it is letting your students know that you do provide some basic, or what you provide on campus, and then what the referral system is. And, even on the website, it's not, there's nothing there. And so if I were a student who needed an abortion, I went to that website, it would look like you did nothing, or you couldn't do anything. So I think that would be part of the plan, is how do you talk to students, how do you let them know who are the providers in the area that you could refer to for any of the care. Really, what is the plan if students are in a crisis and need access to birth control or access to one of the parts of the bill is about vending machines. Like, do you have a vending machine on your campus that has the medications that are necessary? And I think that in Massachusetts, the institutions that were in your situation in more remote parts, those and didn't have a big wraparound health center on their campus, where this is why there was the sort of readiness plan to get the institutions thinking about how they would be able to help their students. And so I completely am empathetic to where you are, and sort of hope that this might help you think more broadly about how you can serve your students in these areas. And maybe it's just mostly about information, and that's not available. And it might be interesting to hear from some students about what their experiences are.
That's why I asked earlier, how many students are involved here and what are their experiences? And Catherine has her hand up, so you just phoned a friend.
Yes, I'm phoning a friend.
All right.
Good morning, committee. For the record, Catherine Lavasser, Director of External and Governmental Affairs for the system. So I am looking at an email that we received when we reached out to our health centers to gather some information in preparation for today. And just for awareness, we do provide, the counselors and nurses on staff do provide information and resources, including for gender affirming care and for abortion services, and they make soft referrals for those. There is recognition that the websites do need to be updated as we move to the unified institution. To be honest, a lot of the website energy is going towards launching Vermont State University's website. And so I think there are some updates that are needed on the current institution sites, but there's much energy being put into the July 1 launch of the new institution. So absolutely recognize that, but wanted to share that information directly from the Castleton Wellness Center.
Thank you. And if you can send us this in writing, that would be helpful because we need the full context. And then to say that you're making a change now with the structure, but one of our concerns in here, and particularly with regard both to the bill that's before us, but to the national environment, there are going to be more students coming to us perhaps as a result of Vermont's position related to gender affirming care. And we're interested in continuing that welcoming environment in our state. So having this plan in place up front becomes very important to that group of students. And it's not the only group, we understand that, but medical services now are becoming more important than ever. I know you mentioned mental health, that's absolutely key. We've got telemedicine work going on to make our state more welcome for folks who need to continue counseling in other areas. But this one, it's unique. We understand that it's a very highly technical in some cases and unique areas. So please send us your testimony, and we do need to have some language in the bill that assures us that Vermont State University will be having a robust environment for students with the need for this kind of care. I think we're all on that same page. It's just how do we make it happen when you're going through so much change as well. We get that, we understand. So if we can have your testimony in writing, and then we will be talking with the Department of Health about how they might help. It doesn't sound like they're going to need to help UVM that much. They're already in a place, but maybe there's some work that UVM can help with as well. So that's enough. I mean, we get it, we understand. So
Very good.
yeah. So just if you could send your testimony along in writing, and for a number of people, this bill is very critical and highly important. You heard Wendy Koenig's testimony earlier, and there are others who feel that way. So we want to ensure that kids coming into the state are welcome as much as possible. That's it.
It seems
And
as if there's
in-state.
the communication
Yes,
of
it is.
it is really what
It-
might be inconsistent or, yes.
Yeah, it is truly, I think that Senator Hardy's pointing that
Yes,
out.
yes, very
Yeah,
good.
that's good. All right, any other questions here or comments? We're good. Thank you. And I appreciate your coming in. It's great to see someone in person.
I know. It's
I
very
know.
nice.
And good luck with all the work. I know there's a lot going on. This is just one tiny piece. But it's
There are
important.
many important pieces.
Many important.
Even tiny
When
pieces
the
are
puzzle
important.
gets put together slowly. Yeah, we know that.
Thank you.
1,000 pieces, a 1,000-piece puzzle. Oh God, I don't want to be one of those. Okay. Thank you.
Fun.
I know.
We could have one on the
Oh, every
table.
Christmas.
Every day,
every
we put in a
Christmas.
few more pieces.
Or Thanksgiving or something. So is David Englander available just to give us a brief intro?
He wants to speak to you before.
All right, so we'll put David Englander off. It's going to give us some more free time, but we might bring our ledge council up. So we have Mary Beerworth here from Right to Life. Mary, welcome.
Thank you. Thank you for accommodating me by Zoom. I was hoping to be there in person, but got that little tickle in my throat, so we're not taking any chances with that.
Thank you. We are very appreciative of that.
Thank you for having me. I have a very short testimony. Should I just begin?
Yes, please introduce yourself for the record, and then we'll welcome your testimony.
Okay, my name is Mary Hahn Beerworth, and I am the Executive Director of the Vermont Right to Life Committee. I have a slightly different focus for you this morning. In consultation with our policy analyst, Sharon Toborg, Vermont Right to Life believes that S37 is unconstitutionally biased in favor of abortion by requiring UVM and the Vermont State Colleges to develop an abortion services readiness plan rather than an abortion and pregnancy services readiness plan. Our state has been through the process to amend the Constitution to protect not only abortion, but also the right to carry a pregnancy to term. I hope this committee will take steps to make sure that those who wish to parent or make an adoption plan are provided as much support as those students seeking abortion. The Vermont Right to Life Committee has concerns around Section 2502, requiring college institutions to develop a readiness plan for providing gender-affirming care, medication abortion for their students, but does not require a readiness plan for parenting or pregnant students. We encourage the Senate Health and Welfare Committee to use this opportunity presented by S35 to include in Section 2502 a provision that UVM and the Vermont State Colleges develop a similarly comprehensive plan to support a student who has decided to continue a pregnancy or to continue to parent a child or children, or to make an adoption plan while trying to complete their degree. In 2022, in Vermont, nearly 1/3 of abortions, 392 out of 1,227 abortions performed in Vermont, involved those between the ages of 18 and 24. The University of Vermont has made some provisions under the requirements of Title IX, which the federal law which prevents discrimination against pregnant and parenting students, but much more can and could be done at both UVM and the Vermont State Colleges. For example, the University of Massachusetts at Amherst has an office for student parents, which can be found online at the link provided in my written testimony, which I will send right away. Their services include childcare subsidies, family grants for non-childcare related and unexpected expenses that would negatively impact academic progress. The website opens with "Welcome student parents. Are you a pregnant or parenting student? Student parent programs is here for you." And those links will be included in my testimony. I'll send that off to Alex right away. And similarly, under the insurance coverage section of S37, if the state is going to eliminate copays and co-insurance for abortion, copays for prenatal care and childbirth should be eliminated as well. And I will also in my written testimony send some paragraphs from a proposed federal bill. It was called the Pregnant Students' Rights Act, and it was introduced in 2022. As far as I know, it has not passed, but it has some interesting suggestions for you. And that's all I have. Thank you for your time.
Oh, thank you. And you will send us your written testimony?
Yes.
Send it to Alex, that'd be great. Okay.
Happy to do so. And thank you again. If I have any questions?
Questions?
Thanks.
No, we're good.
Thanks, Mary.
Thank you very much.
Thank you for having me.
Okay, terrific. So unfortunately, David Englander would like to testify next week, and we're finding some time for him to do that. And so we now have some time, and I'm wondering if we would like to have Amarin or Jen come up and talk with us about maybe some of the things that we've heard about in the bill. Can you do that, or what we've heard in testimony and some of the changes we might like to make, in particular, some of the things we've heard today? Do that briefly.
Yeah, I think so.
We'll just take a few minutes. to do
Yeah.
that.
Pull up the bill language.
Yeah, why don't we do that? Why don't we just start going through the bill a little bit and seeing where we are? I started doing that. I think if there are things that stood out yesterday in particular that might be difficult to do based on licensure or others, that would be helpful. I'll leave it to you.
Are we continuing with 37?
We are on 37. We're trying to sort out some of the testimony that we heard with what is currently in the bill.
For the record, Amber Abergilly, Legislative Council.
And Jen Garvey, Legislative Council.
So I'm going to start right from the top of the bill. The first section of the bill is the definitions. We heard a number of witnesses mention aspects of the definitions that they either have concerns about or would like changes to. Some of the changes that I recall hearing initially were around, just starting from the very beginning, gender affirming healthcare services. We heard some conversation about including more updated terminology, such as not just gender dysphoria, but also gender incongruence. So that was a suggestion that I believe was raised by Medicaid yesterday. And also there was, as part of that testimony, an aspect of insurance coverage around gender affirming care and the language in here, but I'm going to save that for when we talk about insurance coverage. Then there were a couple of comments about just the broadness of the definition of gender affirming healthcare services, and does that need to somehow be narrowed in some way or tied to some sort of national or international standards of care, so that the type of services can evolve over time as that area of healthcare evolves. So that was, those were the items I remember being raised as part of gender affirming healthcare services. We heard a recommendation from Vermont Medical Society that they liked the new definitions that are in the House Judiciary Bill, H89, around legally protected healthcare activity. That bill is due to go on the floor this afternoon in the House. So we won't know for certain what those definitions are coming out of the House until if and when that bill passes out of the House tomorrow. So I would say maybe put a pin in that for the time being, but you're certainly welcome to go and look at the calendar if you want to take a look at the definitions and see how they differ from what's currently in S37. Please feel free to jump in if I'm skipping for something.
No, that's great. And I think we could look at the definitions if that would be helpful, but as Amber said, it may be premature to.
Let's wait until they have the final vote.
I do not recall hearing any testimony about the definition of reproductive healthcare services and suggested tweaks there. Next, medical malpractice insurance. I believe we will have to double check the House Bill H89. Abusive litigation is defined in both bills, so we'll want to make sure that there were no changes in the House bill. And then related to that section is the medical malpractice piece. We have received some written testimony, but not in-person testimony yet on that aspect.
We'll get that next week.
Okay.
Right. We have it. I think we have it scheduled for next week.
So possibly some minor changes there. Moving into the insurance coverage, which is sections 3 and 4. We heard some testimony both from insurers and from Vermont Medicaid that they would like the coverage of gender affirming healthcare services to be limited to medically necessary services or gender affirming healthcare services. And in addition to that, Vermont Medicaid expressed some concerns about having no cost sharing due to their IT system and how they input things. So there was a request that maybe that cost sharing prohibition not be included for Medicaid for these aspects. And there's an explanation about the low amounts of co-pays for that population.
What type of gender affirming care would be medically necessary?
That sounds like a great question for one of the providers.
When we have we've got some OBGYN residents coming in today. So that's
I'm not sure they're going to be able to answer on gender affirming.
Yeah.
Oh, that's true. They will.
We'll
We'll reach out to Dr. Gibson on that one.
Yeah.
So maybe I misunderstood you. You said that somebody testified that they were concerned that it was medically necessary.
Right, I do recall, there being a conversation about presently Medicaid would not, for example, cover gender affirming healthcare services that would be categorized as a cosmetic surgery. While they do cover, gender affirming, I forget the term, but they do cover surgeries related to gender affirming care, but they would not if it was considered a cosmetic surgery. So just narrowing that coverage. The insurers both pointed out that in the definition of health insurance plan, we need to make sure that there's an exception for high deductible health plans to make sure that it's compliant with federal law. And I believe both insurers, witnesses testifying yesterday mentioned that you will have a policy choice about the prohibition on cost sharing for both abortion and gender affirming care services, as that will have an upward pressure on premiums. And there are there are other bills within the State House this year that also propose to prohibit cost sharing, in which case those also could affect. So looking at the larger picture of how many areas of insurance coverage are we limiting those cost sharing aspects.
Just to clarify with the group, I think what I heard in regards to the two insurance representatives yesterday, that when they say that it goes to premium, does premium mean that it goes to those who pay premiums? Is that really the kind of the linkage? Okay, so it's
Like the insurance plan that you pay for. And so if the cost of the premium goes up, you pay more for that.
right.
You still have, they're all conditions that are within your coverage, but the total payment over the year might go up.
And again, just to kind of boil it down to something that I can relate to, what it really means is the cost shift is to those who pay versus those who are supported.
Yeah.
Okay.
Well,
Not completely.
so
yeah.
I think a way to look at it is there are two ways that people pay for insurance and healthcare. One is through premiums, which are the sort of monthly or annual payments that we make to have health insurance coverage. The other are co-payments that we pay when we get a service.
Right.
So you go to the doctor for a checkup and you have a copay that you pay them as you leave. Or you pick up a prescription and you pay for a copay. So what I think they were saying is as you pay less for copays, you're going to pay more for premiums, not just the individual, everybody. The premiums would go up because the health insurance companies would be getting less money from the copays. They would have to make up the difference on the premium level. And it's not necessarily like, if I don't pay a copay, you're going to pay more in premiums. It's if I don't pay a copay, everybody's premiums would go up. And that's an oversimplification, but that's the calculus I think they were trying to talk about yesterday. And if we cut down on copays for everything, then it would be, just on the premium. And there's an argument for doing it, and there's an argument for not doing it. So that's why I'm saying this is a policy decision.
So the thing I heard yesterday was that eliminating copays is probably problematic. So when you squeeze the balloon and somebody's got to pay, that we're all paying copay, everyone's paying copay in the end at some level or another.
But it also depends on the number of people who you're paying for. So if it's a significant risk pool, you have a huge group, then the shift will be greater.
Right.
But if it's just a few, and so the question is how many, and perhaps we can ask Department of Health how many people would be affected by this, then it's different. So, yeah. So we'll ask Department of Health for that. Go ahead, you want to make?
Yeah, and it might be DEVA that would know that, right?
Well, DEVA would be Medicaid, and then we also have private insurance here that we're looking at.
So is the question, how many people would be getting a new insurance benefit who are not currently
Yeah.
necessarily getting that first dollar coverage benefit, and that's the
Yes.
number you're looking to find
And
out?
right now, we're sort of in this place where people are being redetermined for Medicaid, so, but still, it's a number of people seeking this type of care. And it's not it doesn't appear to be a massive number.
Can I just say one more thing that is,
Yeah.
on the copay situation, I think it's also important to think about, we make policy decisions on the type of healthcare that we want to prioritize for people seeking. So for example, there's been a long conversation about, should there be copays for primary care? Because we want people to go to the doctor, and if a copay is going to prevent them from going to the doctor to get their annual exams and their their shots and the things that keep us healthy, that's not a good thing for public health, and that's not a good thing for the healthcare system broadly, because it creates more expensive care down the road. So in I think last couple of years, we've really prioritized no or low copays for primary care. And so, but things that are not that don't have as big of a policy impact or sort of broader impact, maybe having those copays is better or okay, or less bad. So this is a policy choice of saying, this is healthcare that is under attack across our country. And people are not able to access this healthcare. So it's a policy decision for us to say, we want people to access this healthcare. We're saying we're prioritizing this healthcare in Vermont, that it's not only not under attack here, it's being provided in a way that's easy for everybody to access, and there are no barriers for it. And
For
that's
people who have insurance in the state. Yeah.
well, for people who seek this care in the
Seek this
state, because it's not just about insurance, it's about seeking the care in the state.
So anyway, well, so does that answer your question or not? I know it went further than your question, but I didn't want to go all the way around Robin Hood Farm to make sure you got the answer. So let's just,
No, I appreciate it.
yeah,
It's all-
okay. It's a value-based decision that we make sitting around this table. And it's something we have to think about. The insurance companies have said it may raise premiums. And the only way we can tell that is by looking at how many people are affected. And then, how big is the risk pool here, the group that is seeking this care, and then what effect did that have? So. And Senator Williams.
Just to clarify, a question from my own,
Sure.
is the language in this bill says we're not gonna charge them copay.
Right.
Currently.
That's the bill. That's the proposal. Yeah, that's the proposal. Medicaid currently has very, very low copays. $1, $2,
$1 to $3 for prescription.
$3 a prescription. And the service itself is not, some of the services.
Thank you.
Okay, so that was fun.
All right, I believe that covers insurance. There's a Section 5 state plan amendment. The only comment about this was maybe adding the word if needed after shall seek, although it does say if needed
does
later in
yeah.
there, so I will have to check with.
Which one,
Medicaid.
where are we? I'm
I'm
sorry.
in Section 5 state plan amendment.
Yeah, I'm
The
not
agency of
sure.
human services shall seek a state plan amendment from.
Yes, there was a question there about putting as a needed.
Yes,
needed.
I do have that if needed after
Yeah,
federal authority, so
Right.
I will check.
Did they want the
confirm
shall
that.
change to a may?
no,
Or
they
they
just wanted as
it
needed.
Yeah.
Okay.
I'll confirm.
Yeah, check with them and see it,
Yeah.
because it seems to me like it already says. that.
Yeah. it does.
So I know that we're on a roll here, but David Englander from the Department of Health has shown up, which was good. I think what we might do is shift over to David, and then we'll take a little break and we'll hear from the OBGYN residents who are available to us at 10:15.
10:15? Okay, great.
And so, David, thank you for being flexible. I understand that we will have a conversation and that you'll be bringing us your real testimony next week. But I just wanted to make sure folks were understood that Department of Health was involved and just some of your preliminary thoughts at this point.
Sure. Good morning, Madam Chair, and good morning, members of the committee. For the record, my name is David Englander. I'm the Senior Policy and Legal Advisor to the Commissioner of Health. I'm delighted to be before you talking about S37. I do apologize for the confusion about when I was going to appear, so I appreciate your patience
We're good.
in allowing me to do that.
Life is complex.
It does seem to be that way. So I want to be very clear, the Department of Health very strongly supports the intentions of this bill. All of the social, cultural, and political drivers that Senator Hardy just mentioned, the department agrees, and it's something that we need to work on together. The bill itself, and why I was praying for more time, does imagine a tremendous amount of work done by the Department of Health that we don't normally do, in terms of creating plans, approving plans for particular kinds of healthcare, creating certain kinds of reports. There's a lot of complexity in gathering the kinds of information that would be required. So today we're in the process of trying to understand what it would take to actually do the work as envisioned, and we would look forward to working with the committee trying to figure out how we can do that. But as of today, it's not like there are people and resources, information available to do the work that is required by the bill.
So we will have a conversation, Shirley, and that did you hear the testimony that was before us this morning from UVM?
It did.
ESU, that's good. Okay, so that will go into the hopper, and then we can talk perhaps, I don't know, over the weekend or on Monday, and then we'll help to clarify what exactly the committee might be interested in based on all the issues before us. So I just want to say thank you for being here this morning so that folks understand when we come back with proposals, or you come back with proposals, it's based on both general support of the bill.
Yes.
And then what is doable in the department. So appreciate that.
Of course.
I think that's it. I think we're good.
Okay.
Unless there are quick questions here. No.
Or long questions if you.
Long questions or short questions, but I think we're good. Okay. All right.
Can I ask David something about something?
No, something else. No.
Can you give me a call, David, after we go off live?
Absolutely.
I have a question about something else.
That's
Okay.
fine.
Thank
Yeah,
you.
That's good.
That's fine.
That's the value of Zoom.
I was like, he's here and I'm trying to get a hold of him. so.
Yeah, I know. It's like walking down the hallway.
Just call my cell when you step out.
I don't have your cell,
Okay,
but
so
I
we're
think
gonna
you
go
do.
offline.